Yes, sir, please.
Yeah. Hello and good evening, all. Uh, in these times of COVID, actually, this is so difficult way of conducting a webinar because I'm so used to meeting people in person and having talks face to face. So this is what I can say a disruptive way of conducting educational programs that is happening because of COVID. I sincerely hope and pray that you all are okay and you are free of COVID. Please do take good care of yours. Before I start my small talk on paradigm shift in first trimester screening, first I would seek blessings of all my teachers who have been instrumental in seeing where I am today, and to all my students whose love has made me present this talk today. And this talk is meant for my students who have been scattered all over India. Uh, What do we mean by paradigm shift? Paradigm shift is a thought or is an important change that happens when the usual way of thinking about something or doing something is replaced by a new and different way. And what else example than this N95? Suppose you ask any generation today, if you ask any generation today, the moment you say N95, they will identify N95 with the mask. But we remember that for probably for some time again, this N95 was a mobile which was launched by Nokia and was very popular at that time called as N95. So that's what a paradigm shift that is usually coming into picture. If you look at the medical sciences and the medical evolution that is happening, the most traumatic problem or most difficult problem for any patients or any relatives is that often the possibilities presented by medical science march very well ahead of the ethics and the law. And this quest for a perfect baby, we understand there is no any perfect screening test or a diagnostic test option that is a right choice for all parents. So when it comes to understanding the health of women and the health of women or their well-being, I think there are four important concerns that we have in our mind when we are screening women during pregnancy. The first would be first would be what is the risk of this child or this fetus carrying any aneuploidies? What is the possibilities of this baby having any structural or lethal malformation? And two important areas of maternal well-being, that is preeclampsia and preterm birth. So in next 45 to 50 minutes, I'll take you across a thought process about how well we can adapt to this first trimester screening technology in improving the health of the unborn and the health of the mothers that we care for. I will not be going into details of technical details of each topic or each subtopic, nor discussing the techniques of doing something like a nuchal scan. But this is just an overview of what we are going to see, the change that we are witnessing. I'll just take you across the evolution of screening for Down syndrome. It was almost 150 years back that Langdon Down, for first time in 1866, the 1866 mentioned about certain peculiar children who had a peculiar faces, and he called these babies as Mongols. Now, Mongols is a bad word in a today's sense because it depicts that this is an inferior race. But remember, these were the times of Darwin, and the evolution and evolutionary impacts were being discussed in great fashion. And Darwin said that certain races will have, in as the race evolves, there are certain beneficial mutations that come into picture. And if these mutations or these changes that are coming are beneficial, the race becomes superior. Sometimes the mutations could be bad and the race can become inferior. So if the mutation is good, that mutation is carried over into the further generations. And if you are lucky enough, you become a superior race today that which stays in a Lokhandwala complex in Mumbai, or perhaps Tarabai Park in Kolhapur, or you can say about Jangli Maharaj Road in Pune. So that's how a superior race confirms an survivor advantage to the baby, survivor advantage to that particular person. And if something goes wrong, then the evolution pushes back that person behind, and therefore that person becomes a Mongol. So the initial idea of calling these babies of Down syndrome was as Mongols was this evolutionary concepts that Darwin had put forth in front of Downs. But it took almost another 100 years to understand what is the reason behind this abnormality, and it was in 1959 that Jerome, a French physician, a French pediatrician, who discovered that this is a trisomy 21, an extra copy of chromosome which is there at chromosome number 21, that leads to the phenotypic expression of the babies that we see and call them as Down's babies. From 1959, it took another 10 years to understand that probably the maternal age is which is important for babies to be having Down syndrome, and the older mothers will give rise to a higher chances of babies with Down syndrome. And for some idiotic or some illogical reason, the British government thought that after the age of 35 years, all women should undergo an invasive procedures to understand what is the reason of is this baby suffering from Down syndrome. So for last 100 years or 100 last 50, 60 years, our brains have been brainwashed, or our minds have been brainwashed, that a woman who is age of 35 and above is going to give rise to birth of a baby with Down syndrome. And if the mother is less than the age of 35 years, there is no risk of this mother delivering a baby with Down syndrome. So probably our minds are washed in that thought that one fine morning the woman turns into her 35th birthday and suddenly becomes old. Suddenly her ovaries become old and her chances of delivering the babies with Down syndrome goes high. Then comes 1980s, and this was age restricted amniocentesis or maternal age related amniocentesis, whose pickup rate we know is about 30% and not beyond more than 30%. So almost about if the population is destined to have 100 babies with Down syndrome, only 30 babies would have been picked up by doing an amniocentesis. But that means this mother, we are exposing almost 100 mothers to pick up a baby with Down syndrome by an invasive procedure which carried its own risk. We enter into 1980, and Matt Kurtz is another doctor who is credited with the discovery of alpha-fetoprotein and its serum alpha-fetoprotein and its correlation to baby with Down syndrome. His secretary was pregnant, and that time the mothers underwent a serum alpha-fetoprotein levels to understand the risk of neural tube defect. Since her secretary's report came as low, the alpha-fetoprotein levels came as low, Matt Kurtz congratulated his secretary, and said, "Good, you are not going to have a baby with spina bifida." The mother delivered a baby. Baby did not have spina bifida, but the baby had Down syndrome. This secretary was smart, so she underwent through records of all the patients that had been booked with Matt Kurtz, and then she understood that though low alpha-fetoprotein levels reduce the risk of neural tube defects, it increases the risk of baby being born with Down syndrome. She put these numbers to Matt Kurtz. As it happens in medical evolutions and medical discoveries and the credits for medical inventions, the secretary was fired. Matt Kurtz took all the credit, and so was born the triple test. It took another 10 years for Nicolaides to identify that these babies with Down syndrome will have an excessive collection of fluid behind the nape of the neck, which is called as nuchal translucency. And the thickness of the nuchal translucency corresponds to the chances of the baby being born with Down syndrome. And the revolutionary introduction of nuchal translucency in the first trimester scan began, and this is an era of first trimester screening. Of course, then later on we know the first time to do the first trimester screening, various parameters were added like nasal bone, ductus venosus, tricuspid regurg, which increased the detection rates of a complete FTS to almost 93%. Then comes low, and though we today discredit Chinese people with COVID and the COVID onslaught that is happening all across the globe, Low is a Chinese scientist who discovered that those patients who have malignancy have got cell-free DNA circulating in their body. Because as the cell dies, the DNA are freed from the cell and this DNA are circulating. So Low thought that if the malignant patients have cell-free DNA, why not the pregnant women? And therefore, he started studying the pregnant women's blood. And to his surprise, he studied that by looking at the cell-free DNA content and the fetal fraction of the cell-free DNA, we could diagnose whether this baby is suffering from Down syndrome. And this is an era of cell-free DNA. Today, we know cell-free DNA, the accuracy of cell-free DNA is almost 99.9% as far as the diagnosis of Down syndrome is concerned. So we have over 150 years, we have evolved from understanding what is meant by Down syndrome, what caused Down syndrome, how we could pick up Down syndrome by applying various tests. And today we have come to an age in 2020s where we can pick up Down syndrome with a 100% configuration. But then we know All screening tests, these are all screening tests. The main aim and objective of screening test is to identify an individual which is at risk and then apply further diagnostic tests to see whether the patient is really suffering from any disorder or not. So this is a decision tree actually. When the patients will undergo a screening program, this screening program will classify the women or classify these patients into three different categories. One group of women who have a low probability of developing a disease. Another group of women will have a high probability of developing a disease, and another group of women would have an intermediate probability of developing a disease. And then we know what is the action to be taken at the two extremes, that is the low probability and the high probability. It is the intermediate probability group that is always a cause of concern or cause of dilemma. Because when the patient gets a screen positive report, the understanding for the doctor and the understanding for the patient is totally different. What we today see that the doctor says further tests are necessary, but for the lady, she is afraid that this baby is affected. So the moment you get a screen positive report, the only one understanding that goes into patient's mind is that this baby is affected. So the cardinal mistake that we make in interpreting the reports of FTS is that low risk means the pregnancy is not affected, while high risk means the pregnancy is affected. So this is not the way. This is not the way how the evidence should be read. Royal is a British chemist, and in the evidence-based medicine, this person is very famous because whenever you are going to interpret the evidence, we need to ask three questions. What does the present evidence say? What should I believe? And what should I do? And the answer to this question number 3, that is what should I do, will depend upon what should I believe. And therefore, the utilities or the way we are going to do the screening test play a very important role, because that is the evidence on which we are going to base our whole clinical decisions. If this test on which we are going to do all our decision making is right and appropriate and is approved by accredited organizations, then we can accept the evidence into our clinical practice. But if they are not done in a rational, methodical, objective manner, then this is a very poor evidence and which is likely to do more harm to the patient rather than doing any benefit. So these errors or understanding errors, the first error that comes into practice is when we do not give much attention to the utilities. The utilities is what we mean. What do we mean by utility? Is the capacity or a commodity or a service which is usually to satisfy a human need. In medical profession, this could be the sensitivity and specificity of the test being done, the various platforms and the methodologies, how is these tests are being done, and are these methodologies being accepted by various foundations. So as far as the utilities are concerned, in first trimester screening, today we have 3 options. We know there are multiple options. I'm not going to discuss all these options because that will lead unnecessary to confusion. But we know today the women will have 2 important options. One option in the first trimester called as a combined FTS. Combined FTS is combination of ultrasound parameters with the serum biochemistry. And second trimester, this is replaced by the quadruple test where we add inhibin to the combination of another 3 biochemical markers. And depending upon either FTS, combined FTS or quadruple test, we classify our women into low probability, intermediate probability, and high probability criteria. And then we are going to offer them further screening, further diagnostic procedures. All this discussion was true when cell-free DNA did not come into our pictures. But now with advent of cell-free DNA, I think the whole scenario of screening for aneuploidies is changing. Very recently, another paper has come from Dr. Suresh Mediscam, and this is something called as enhanced FTS, where the major hurdle of combined FTS was availability of people to do nuclear translucency scans. So here in enhanced FTS, what Dr. Suresh did was to calculate or to measure alpha fetoprotein with the first trimester serum markers, and this is called as enhanced FTS. And then they have promoted a model taking into account all these 4 parameters, and the detection rates of this serum only protocol is 80% at a 5% false positive rate. The only advantage of an enhanced FTS would be it does not require a accredited sonographers to do a nuclear translucency scan. So in one way, probably this may take out the burden of non-availability of anti-scans at many places. However, we remember anti-scan has also got certain additional advantages which we'll cover later on. And then the research by Lowe in 1997 disrupted our whole thought process by introduction of cell-free DNA. What do we mean by cell-free DNA? As I've said initially, almost 10% of the maternal DNA, 10% of the fetal fraction is circulating in maternal blood at the time of pregnancy. And this fetal fraction comes from the apoptosis of the placental cells. When the cells are going into the maternal circulation, they die, their cell walls break, and they will release their DNA into the circulation, what we call as cell-free DNA. Normally, we know the content of cell-free DNA in maternal blood during pregnancy is about 10%. And then we use a very costly machine to understand what is the fraction of fetal DNA and what is the fraction of maternal DNA. The machine will do what is called as massive parallel sequencing of all the genes, rearranged all these chromosomes, and then will tell us, are there any extra number of DNA in this maternal blood? Say, for example, this maternal blood was destined to contain only 10 copies of 10 copies of chromosome number 21, and now it has got 15 copies of trisomy 20, 15 copies of chromosome 21. Then we know there is another 5% of fetal fraction which is coming into the maternal blood. So this is a baby, or this fetal fraction is coming from a pregnancy which is affected with Down syndrome. This is a very simplistic way of telling you how a cell-free DNA technology works. Of course, there is a lot of technology which goes into understanding and developing these protocols. Is this a good technology? Today we know cell-free DNA is established as the most superior way of understanding the risk of Down syndrome or risk of chromosomal aneuploidies. There are many publications, many papers which have come, and they say the detection rates are closer to 99.9%. So as far as understanding, or as far as the objective is to pick up the baby of aneuploidies, I think cell-free DNA scores over all other screening modalities like combined FTS or quadruple tests. One thing we remember though, the accuracy of cell-free DNA is 99.9%. It does not mean that if the test comes as positive, the baby is already affected. There are certain things called as placental mosaicism, where the placental DNA structure may be little different as compared to the fetal DNA. Therefore, if you get a cell-free DNA cell-free report as a screen positive, then we should be doing a follow-up CVS or amniocentesis to confirm the fetal DNA, and then they take a decision. So please do not terminate the pregnancies if the results come as positive on cell-free DNA. There are certain limitations of cell-free DNA technology also. It does not detect unbalanced translocations, deletions, or duplications. It cannot predict late pregnancy complications. As of today, it does not work on single gene disorders. It will also fail if there is a high degree of mosaicism. And today in India, I think the cost of cell-free DNA is little prohibitory as far as the routine or universal screening program, as far as the routine or universal screening programs are concerned. If you look at all our international bodies today, we know the recommendation is that the woman should always be offered an option of aneuploidy screening, including NIPT or diagnostic testing, irrespective of maternal age. We need to forget that if the woman is beyond 35, her chances of delivering a baby of Downs is very high. If you look at the society, 80% of the babies with trisomy 21 are born in otherwise low-risk pregnant women whose age is less than 35 years. If you look at our contribution, or if you look at the contribution of mothers for the pregnancy, you will find hardly 5% of the pregnant women will qualify for pregnancies beyond age of 35 years. So please take out this notion that a woman, if she turns out, it becomes the age of 35, her chances of delivering a baby with Down syndrome will be very high. So it is a reproductive right of every woman to understand what is the chance of her baby suffering from aneuploidies. If NIPT fails to give results, then the alternative testing should be discussed with the patients because of the increased risk of aneuploidy. And false positives and false negatives do occur with cell-free DNA. Therefore, diagnostic testing should be offered to any patient with a positive NIPT result. So if we introduce cell-free DNA as the prime modality of understanding the chances of Down syndrome, what are we going to achieve? Number one, It is not meant to detect babies with Down syndrome and destroy them. But understand, by doing invasive procedures, we are losing many more pregnancies than by picking up a baby with Down syndrome. Today, if you look at the scenario in India, the way the triple test and the quadruple test are done on unscientific manner, and majority of the patients do not get a proper explanation to understand why they are screen positive. Many more pregnancies are lost simply because their screening tests are coming positive. Of course, a selfie DNA test will reduce the anxiety, will increase the detection rates, will reduce the false positives, and very soon in future it will be available to all women. So what pathway we can have? And this is a very nice paper. This is just a recent paper that has been reported, and it compared three pathways: a combined FTS alone, a cell-free DNA alone, and a quadruple test. And the pickup rates of cell-free DNA alone was 89%, cell-free DNA was 100%, while quadruple test was around 60%. But what we remember is that of all those patients whose test came negative, like a cell-free DNA test coming as low risk, or the FTS test coming as low risk, what was the chances of this mother delivering a baby with Down syndrome? Because false negatives is a big problem for us. We are not going to take any decisions if the reports come false positive. And if you look at the analysis, we find that in cell-free DNA, there's hardly a baby if the cell-free DNA report comes as normal or cell-free DNA report comes as low risk. There was not a baby with Down syndrome which was being born to these mothers. Majority of the trisomies that were on trisomy 14, trisomy 6, and these babies are naturally lost during the course of the pregnancy. But if you look at combined FTS, there were 10 babies which were born with Down. 10 babies had Down syndrome and 5 were live borns. These are the mothers who went home with a low probability report in FTS or combined FTS. What does this mean? This means that if your objective is to screen for Down syndrome or screen for aneuploidies, then the appropriate technology will be cell-free DNA and not a FTS. So we should understand what is the objective of our doing this test, and then what best can be done to understand all these reports. That's what I said. If the primary purpose of prenatal testing is to detect trisomy 21, I think cell-free DNA is a superior test as compared to combined FTS. I will just give you our results here. In last 3 years, we did about 600 and almost close to 600 amniocentesis. And of the 600 amniocentesis that we did, the few patients were patients who came from our unit, and few were the referred patients. About 4,000 women underwent a FTS according to the FMF criteria. 67 were screen positive, 4 trisomies confirmed. So we had to do 15 amniocentesis to pick up one baby with trisomy 21. But for those referral patients who came from outside, whose FTS or whose quadruple tests were done on a non-FMF platform, there were 423 women, 12 trisomies confirmed. We had to do 35 amniocentesis to pick up one baby with Down syndrome. So this is the difference between a appropriate accredited platform versus a non-accredited platform. But if we go back to our old friend, that is ultrasound, there were 139 anomalies seen on ultrasound, and these patients opted for karyotype. 11 trisomies confirmed. We had to do 12 amniocentesis to pick up one baby with a aneuploidy. What does it mean? It means that still ultrasound is a far superior technology to pick up abnormalities and pick up those babies which are destined to have a genetic defect. So the first practice implementation point that I would suggest is that in your women, let women gather literature, give them pamphlets. Now YouTube channels are so famous. Many of the doctors have their own YouTube channels. They have their own Facebook channels or Facebook pages. Please put all information there. Let women understand what they are going to experience during their pregnancy. Do a first good quality transference scan to understand fetal viability and dating, which is very important as far as the subsequent scans are concerned. Discuss aneuploidy screening at the first prenatal visit itself, and review all options for aneuploidy screening and diagnostic testing. One pathway that I would suggest at this juncture is to offer a combined FTS to all pregnant women between 11 to 13 plus 6 weeks. Understand what is their risk probability. If the probability is less than 1 in 1000, these women can go back home reassured, and we call them back for our 18 to 20th week scan. If the probability is more than 1 in 10, then we know here we are interested in picking up really and we don't want any intermediate test. These women will undergo an invasive procedure to see whether the baby is suffering from any chromosome abnormalities. And the middle group, where the probability is between 1 in 10 to 1 in 1000, can undergo a cell-free DNA to see whether there is really a chance of this baby developing aneuploidy or not. If your cell-free DNA shows a screen positive result, we go ahead and do amniocentesis. If the screen positive, the results are screen negative, we can reassure the woman that her chances that her baby is normal is almost 99.9% as far as the Down syndrome is concerned, and she can go home and sleep nice, sleep well. So consider, is there a separate class of women where we should be considering cell-free DNA as the primary option and rather than depending upon the combined FTS? Yes. The answer would be if the maternal age-related risks are very high, if the patient has got a positive serum screening, if there is an ultra abnormal finding on an ultrasound, if the family has got history of previous babies with Down syndrome or any other genetic malformations, or if the parents are suffering from any translocations involving one of the tested chromosomes, then these will be a very small category of women who will be subjected directly to cell-free DNA and not to the combined FTS pathway. Rest all women will undergo a combined FTS pathway. Of course, agreed, as far as the universal screening modality is concerned, cell-free DNA will still score, but the cost is prohibitive as of today in India. Therefore, we'll have to identify which women will benefit from a combined FTS and which women will benefit from directly going for cell-free DNA. Will it replace anti-scan cell-free DNA? Will it replace anti-scan? The answer is big no. NIPT or NIPS or cell-free DNA has got its own objectives, and that is to understand whether the fetus is suffering from any aneuploidies. Well, as far as the FTS is concerned, here we are looking at the nuclear translucency, the various fetal parameters, certain maternal parameters, and we know there are three important things that the FTS is going to tell you. It is also going to tell you about structural anomalies. It is also going to tell you about preeclampsia and fetal growth restriction risk, and it will also give an idea about any anomalies in the baby. And of course, our third scan, that is the 20-week scan, which is a very important scan because this is a follow-up scan of all those fetuses which have got missed anomalies. Again, at 20 weeks, majority of these anomalies will be picked up by 20 weeks. This is a time to understand again growth and the test of fetal well-being as the baby grows further. The second concern that we have in our mind is picking up babies suffering from structural malformations. And will at 11 to 13 plus 6 weeks is a right opportunity? The answer is yes, again, because the machine resolution is far better, improved resolution, and a very standardized way of how we are going to do the scans will lead to pickup rates, very high pickup rates. Those of who are coming from Mediscan school of thought, and we very well know the Mediscan's rule of three, where we divide the fetus into three different regions, three planes, and three structures to be seen in each plane. I very fondly remember my teacher, Dr. Suresh, saying, if you do not see what you should see in the given plane, or if you see more than what you should see in this given plane, suspect an anomaly. So if you do your methodical scans in first trimester again, this is possible. Is rule of three practical? The answer is again yes. This is a very practical rule, and we use three different buttons on machine, that is zoom, Cinelu, and shift to transvaginal scan if the picture is not seen. So zoom is a very good option. We just zoom out the area, look at the fetal areas again. Use Cinelope so that you can scroll through the images to understand, especially so the Cinelope will be very important as far as screening of heart is concerned. And majority of us will have machines with transvaginal capacity, and you can shift to transvaginal route to understand fetal anomalies in a much better fashion. If the woman is obese or if the abdominal picture is not good, do shift to transvaginal scan. Obviously, remember, doing a good quality first trimester scan requires patience. This is not a 5-minute job. So don't be in hurry to finish off FTS in first 5 minutes only, then just take second patient. what anomalies we can pick up. And if we look at the baby in a very systematic way, right from the head to the toe, we can pick up certain lethal malformations by 11 to 14 weeks. If you look at the head, we can definitely pick up acrania, all over holoprosencephaly and encephalocytes almost with 99 to 100% accuracy. There would be certain thoracic anomalies like congenital diaphragmatic hernia, HLHS, that is hypoplastic left heart, tricuspid or pulmonary atresia, ASDs, complex heart, ectopia cordis can also be picked up. Spina bifida, if you look at the indirect markers like internal translucency, we can again diagnose if there is a spina bifida. We can also pick up if the anterior-abdominal wall continuity is there or not. And if you look at the anterior-abdominal wall, we can pick up the anterior-abdominal wall related abnormalities like omphalocele or body stock anomalies. If you look at the bladder and the bladder is distended, then we know we are looking at a baby with a lower urinary tract obstruction, megacystis. If you look at the limbs and if you do not see a baby limb, then we know this is a baby could be absence of any extremities, or there could be some lethal skeletal dysplasias where the bones are not seen well. So if you just a pictorial graph to see how these babies are, you can see here is a baby with encephalocele or acrania or lobar holoprosencephaly, a upturned mesenteric artery, which is again a marker of congenital diaphragmatic hernia. If you put color in your first trimester scan, you can pick up the chamber-related anomalies. If you look at the internal translucency, we can diagnose spina bifidas. You cannot miss on a distended urinary bladder. Of course, if you look at the anti-abdominal wall, you can see the omphalocele and exomphalous abnormalities. Do a good screening of the extremities, and we can pick up extremity-related abnormalities also. We can also pick up some non-fetal related abnormalities like hydrops at this juncture. So optimizing anomaly detection, as I've told you, shift to Zoom, shift to Cine, shift to TVS, a methodical examination, and appropriate use of Doppler. So if you have a methodical way of doing scans, all those abnormalities which are in red can be picked up within 100% confidence. The ones with green will require little patience and little training to be picked up. So where are we? There will be certain set of anomalies which are always detectable. There will be certain set of anomalies which are potentially detectable, but you will require little patience and little extension of your ultrasound skills. And there will be certain anomalies which will remain undetectable even at first time scan, especially abnormalities like microcephaly or bowel-related anomalies or non-lethal skeletal dysplasias, which will not be picked up by your 11 to 14 scan. Is this possible? Again, this was one of our papers in 2010 Hyderabad, where of all anomalies that were seen, we could pick up 71% of the anomalies at 11 to 13 weeks. All lethal malformations were picked up by 11 to 13 week scans, and rest of the remaining anomalies, 26% were picked up at 20-week scan, and 3% anomalies remained undetected. These findings again confirmed with another multicentric paper, and this is a paper by Pratima Radhakrishnan, whose numbers again matched the same. And this again a multicentric paper which says that almost 70% of the lethal malformations can be picked up at 11 to 14 week scan. Why early detection is important, I think for this intelligent crowd, I should not be dwelling more on this, why early detection. As early as you pick up the lethal malformations, I think the ease of termination and the psychologically less distressful situation for the pregnant woman, it is important that we pick up problems in the first trimester itself. But if we shift our focus from the baby to the mother, and then we understand preeclampsia is again a burning problem for us. If you look at the incidence of preeclampsia, irrespective of the nation, irrespective of the race, irrespective of the area where you live, irrespective of where you live in Lokhandwala complex or Dharavi, the incidence of preeclampsia is between 5 to 7%. This is number one killer for mothers. This is number one contributor for maternal morbidity. Unfortunately, in spite of such bad scenario, we do not have any screening policy guidelines into our clinical practice. There is no good national, local, or individual policy to identify which women are at risk of developing preeclampsia. Again, I go back to one of our papers, and this was from Sweshampan Memorial Medical College, where I did my MD. And this is the first one is our paper in 2003, which told that the maternal mortality rate in eclampsia was 2.8%. The same institute, another paper has come in 2017, and the maternal mortality for pre-eclampsia is, of course, from eclampsia is 3.3%. What happened? What has gone wrong? So almost 17 years, the figures of deaths because of eclampsia and the maternal morbidity because of severe preeclampsia are remaining the same. Why are we not able to conquer preeclampsia? And the answer is we do not give any serious thought to the problems of preeclampsia. If you look at the international bodies, something like NHS, towards which we look at with confidence, or the ACOG, they have only maternal history and maternal parameters as the important things to understand which lady is at risk of developing preeclampsia. So you look at maternal race, look at maternal age, look at coexisting diseases, look at issues like diabetes or pre-existing hypertension, and then only understand whether the risk of this lady developing preeclampsia is high or not. In India, now recently there has been a concept of Justice score where we assign a score to women, and depending upon this Justice score, we classify the women as high risk for developing preeclampsia versus low risk for developing preeclampsia, and then initiate therapy. But all these things are very subjective, and all these things are very depending upon the maternal history alone. But we remember the world is moving ahead, and this is a very interesting and path-breaking paper that came from FMR and the ASPRI trial. Today we know the prediction of eclampsia model has become very objective. So we determine what is the background risk or a priori risk of this mother developing preeclampsia by looking at maternal characteristics, her medical and obstetric history. Then we measure certain biomarkers and ultrasound parameters which will modify the prior risk, and then we do design a intervention. So this is a more easier way. What parameters we look at? We look at maternal history, what I told you initially. Then we look at the mean arterial blood pressure. This blood pressure should be measured in a sitting position and not in women lying down, not using a mercury sphygmomanometer, but with an automated digital machines. Then we shift to a uterine RT-PI, and then we measure certain serum markers, that is PAPE and placental growth factor or PLGF. Again, most important thing we remember is that the measuring blood pressure is again a science. It is not a art. The blood pressure has to be measured in woman who is sitting comfortably with the arm at the level of the heart, and an appropriate cup size is chosen. The arm is very well supported, and we measure the blood pressure using a automated machine. Two blood pressure readings in both arms. Both arms we measure separately. Take three readings in each arm. Take the mean of these three readings and use this to calculate the mean arterial blood pressure. Then we shift to uterine RT-PI. Again, this is a very methodical way of doing a uterine RT Doppler, is to set a sampling gate of 2 millimeters as close to cover the whole vessel. Remember, the peak systolic velocity should be more than 60 centimeters per second. And then we obtain three similar looking waveforms and calculate the PI. PI on right side, PI on left side. Both are combined together to calculate the mean PI, and this mean PI will be converted to norm value depending upon the gestational age. And then obviously we take maternal blood, we do either PAPE and PLGF and understand what is the levels of these biochemistry markers. Using this model, if you look at the detection rates of preeclampsia before 34 weeks, detection rates of preeclampsia before 37 weeks, and detection rates of preeclampsia after 37 weeks, they're extremely high. This modern modality or this protocol of screening women for preeclampsia will identify almost 75% of women who are destined to develop preeclampsia before 37 weeks of gestation. This was combined. This FMA protocol or this ASPRI trial protocol was compared to the NHS protocol, and we found what is seen, and it's very interesting. And this NHS protocol is similar to one which has been promoted in all other countries, that is depending on the maternal history and maternal findings alone, and not giving any considerations to the uterine artery, mean arterial blood pressures, or the placental growth factors. And this NHS protocol will pick up for the same patient. 47 patients, 40%, 47% of the pregnant women were identified with preeclampsia, as compared to 90% of the women who could be identified. 90% of the women who potential class of women developing the preeclampsia were identified using FMF protocols. Again, if the patient is a nice guideline positive and if FMF screen also positive, then her chances of developing preeclampsia are extremely low. But what will happen if the patient's NHS criteria is she is screen positive, but FMF wise she is screen negative? Look at the risk factors. Her chances of developing preeclampsia are extremely low. What does it mean? It simply means going by history alone is not a good way to screen women for preeclampsia. Of course, in our practice, it will depend upon what protocol we are going to observe in our clinical practice, and the protocols could be different depending upon history alone. We know only 50% of the women will be identified, but if you combine mean arterial blood pressure, uterine RT-PCR, and placental growth factor, today we know there's another nice paper which has come which says about PAPE, inclusion of PAPE, and this modality will identify 76% of women who are destined to develop preeclampsia. So there are two extremes now. On one hand, we have history alone protocol, which is going to identify only half the number of women, and another protocol which is going to identify almost 3/4 number of women who are destined to develop preeclampsia. Well, we know there is no role of bed rest, no role of salt restriction, no only role is calcium. If the patient is calcium depleted, the only thing that works is aspirin. And if the lady has got a risk of more than 1 in 100, we know she will require aspirin at a dose of 150 milligrams to be given at bedtime. And then, of course, she will go for uterine artery, repeat uterine artery at 20 weeks and another scan at 24 weeks. By applying this protocol to our clinical practice, you will see that the reduction in the incidence of preeclampsia before 32 weeks is staggering 89%. Reduction in preeclampsia to before 34 weeks is 82%, while reduction in the incidence of preeclampsia will be 62% before the age of 37 years. And this is a huge advantage or huge advancement that science is giving, and I think the time has come to pass on this advantage to the pregnant women. So my second practice recommendation or practice implication would be what we remember is that the dose is 150 milligrams, not 71 milligrams, not 80 milligrams. It is 150 milligrams because some women will exhibit aspirin resistance at low dose, and the optimum effect is seen when the dose reaches 160 milligrams. So the dose is 150. Please forget your 71 milligrams aspirin or 80 milligrams aspirin. We start the aspirin at 12 weeks because that is the time of the first trophoblastic wave which is occurring. And if the placentation is going to be impaired, this is the time to intervene. We stop the aspirin by 36 weeks because we really do not know will there be any potential problems like bleeding for the neonate. The time the drug should be administered is bedtime, because a very nice RCT which tells us that aspirin given at bedtime offers more benefits than if it is given in morning time. Probably the patient compliance is very good. What outcome we remember is that we are trying to avoid the onset of the preterm preeclampsia, that is before 34 weeks of gestation. And the algorithm that we should use in our clinical practice I have described. So this simple white tablet will lead to reduction in the incidence of preeclampsia before 34 weeks by 80%, reduction in preeclampsia before 37 weeks by 65%, reduction in the incidence of abruption by 30%, and reduction in the NICU stage because of the preterm delivery by 67%. Today we know this algorithm is accepted by FIGO. And this is a very recent FIGO guideline on screening women for preeclampsia, and it says the same what has been said in my earlier slides. Is it difficult? The problem, or people feel that such a modality is difficult. We can have our own preeclampsia screening clinics. Establishing a preeclampsia clinic is not big deal. It is not a rocket science. What we need to do? We need to train a staff or train a doctor to measure the blood pressures and document the history properly. Then we should be doing the uterine artery Dopplers carefully to calculate the uterine artery PI. Anyway, we are sending the bloods to the lab for your FTS. The same blood we are going to use. And we use all this information, the mean arterial blood pressure, the uterine artery PI, the serological, the biochemistry, into in software and understand what is the risk of this lady developing preeclampsia. If this risk comes as to more than 1 in 100, we know the answer is very simple. It is to start a small tablet of 150 milligrams aspirin to be consumed at bedtime and to be continued till 36 weeks of gestation. So the point number two, the practice implication point is that we should start offering preeclampsia screening to all pregnant women at 11 to 13 weeks. Understand what is the risk of this lady developing preeclampsia. If the risk is less than 1 in 100, then we offer a routine care. If the risk comes as more than 1 in 100, we start with aspirin 150 milligrams, continue till 36 weeks. Maybe repeat a uterine artery Doppler at 24 to 26 weeks. Concentrate more if the uterine mom value is beyond 1.5 even at 26 weeks of gestation, because this is the time by which the whole trophoblastic invasion wave is complete and the placentation is proper. So if the PI is still on the higher side, then we know really her chances of developing preeclampsia will be very high. Simple formula. Aspirin 150 milligrams. I just want to stress only one point. The dose of aspirin is 150 milligrams, not 75, not 71, not 81. It is 150 milligrams to be given at bedtime and to be continued till 36 weeks of gestation. There are certain questions that people commonly ask. Can we start aspirin after 20 weeks? It will lead to very modest reduction in the chances of preeclampsia, and that's almost hardly 10%. Should we stop by 20 weeks? Say suppose the uterine mom comes down to normal. Should we stop aspirin? The answer is no. It still helps in improving the placental perfusion. And we remember the late onset preeclampsia is really a manifestation of a underlying metabolic disorder rather than impaired placentation. So aspirin is going to help. So don't stop aspirin. When to stop aspirin? I think I have answered that. It is after 36 weeks. Well, this is a very funny question that we get on all platforms. If you say so much about aspirin, then why we should not give aspirin to all women? It is a cheap drug. It is a simple drug. And if aspirin is so beneficial, why not to give aspirin to all? This is a very funny situation. We remember if you use aspirin like you are using a tablet of calcium or iron, it will lose in importance of giving aspirin. So the compliance will be much better if the patient is high risk. We still do not know are there any associated complications of using universal aspirin. And then we know there is a grand old mother, grandma sitting in the family telling, look lady, if you consume a lot of drugs, your baby will become big and then there will be difficulty in delivery. So should we be using universal aspirin? The answer is again no. I think we'll not go into that, and I'll come to another fourth important topic, and that is understanding preterm birth, a challenge. In spite of decades of research into understanding the labor process, we have not been able to bring down the incidence of preterm birth. If you look at the amount of preterm babies that are born in India, the number is 3.5 million. This is world's number one cause of newborn deaths, and those babies which survive from their NICU stage will suffer from various disabilities like cerebral palsy, sensory deficits, learning disabilities, and respiratory illnesses. So preterm birth is a challenge for we all. We know there are at least 6 interventions which are there to avoid the incidence of preterm birth, and that is to prevent a non-medically indicated late preterm birth, progesterone supplementation, surgical closure of the cervix with cerclage, prevention of exposure of pregnant women to cigarette smoke, judicious use of fertility treatments to decrease the incidence of multiple pregnancies, and dedicated preterm birth prevention clinics. The whole issue is how do we identify which woman is at risk of delivering early. The cervix, why the cervix fails, we really do not know. There are two components of cervix. What we understand is a fibrous connective tissue, which is responsible for the tensile strength, and the muscle. It could be a defect in the tensile strength at the cervicoischemic junction. And I shall not go into this. We have only two modalities of screening or understanding the risk of preterm birth. We know there's one definitive factor, that is cervical length. And there are so many papers which tell us that if the cervical length is less than 25 millimeters, this is going to identify almost 50% of all spontaneous preterm births, and this provides the best likelihood ratios for birth before 32 and 34 weeks of gestation. So this is a definitive way of understanding the risk of preterm birth. There are so many studies which are coming on fetal fibronectin. But as of India, as of today, we do not have access to fetal fibronectin. There are certain supportive factors like prior spontaneous preterm birth before 37 weeks, prior premature rupture of membranes, poor weight gain, lower socioeconomic status, maternal habitus. These are supportive factors for preterm birth. So, although a history, but what we understand, although a history of spontaneous preterm birth confers a higher risk of recurrent preterm birth, it amounts only for 7% of women who will deliver preterm. But to be called as a high risk woman, what is the cost of this? Is loss of one life. That this patient delivers preterm, loses a baby, now gets a diagnosis that she is high risk, and then she will undergo screening in her subsequent pregnancies. This is not the way. This is not the way a screening should be done, and the screening should not be done at a cost of one life. Cervical length, what we remember, it is not a static measurement during pregnancy, but it is rather a continuum moment rather than a dichotomous variable. A normal length does not necessarily is an assurance of term delivery, and therefore IMS et al. Have proposed a model of continuum of cervical compliance, such as other body biological variables like height and weight. As they keep on changing, the cervix will also keep on changing during the pregnancy, and this is very important that we understand that. How do we understand the cervical length? Is to measure the cervical length and understand the history. Measuring the cervical length is by using only a transvaginal route. It is a guideline based of measuring the cervical length. If you go to the FMF website, there's very nice teaching video about how to measure a cervical length using a transvaginal method. And then we measure the serial measurements, take the mean of these. And the FMF has suggested a cutoff of 15 millimeters. And the gray zone of decision making is between 1.5 centimeters to 2.5 centimeters. We also look at what is called as amniotic sludge. So if you are doing I'm sorry, the videos are not playing. When you are doing a scan, if you see a sludge-like thing over the internal os, sludge is something like debris into the amniotic cavity, and if such a sludge is seen, again her chances of delivering a baby preterm will be extremely high. So two things we observe on transvaginal scan is what is the cervical length, how the internal os looks like, what is the configuration of the internal os, and is there a presence of any intra-amniotic sludge. If there is an intra-amniotic sludge, we know her chances of having a subtle chorioamnitis are high, and this lady is likely to deliver. So the FMF suggests another model of understanding the risk of preterm birth is depending upon the maternal age, prior history of preterm births, mid-trimester cervical length, and what is the prediction rates? 38% for maternal factors alone, 55% for cervical length alone, and 69% for the combined testing. So if you use all three parameters, that is age, the prior history, and the mid-trimester cervical length, then we know we will be able to identify at least 70% of the women who are at risk of landing up in spontaneous preterm birth. But this is very funny. This is a problem of cutoffs, and we as obstetricians are carried away in a false sense of security by numbers. Nuchal translucency of less than 3 millimeters means no downs. The cervical length of more than 2.5 centimeters means no chance of spontaneous preterm birth. A woman more than age of 35 years means high chances of Down syndrome. So we understand numbers are not important. As far as cervix is concerned, cervix is a dynamic organ. Its strength will vary as the load increases. So it is a tussle between the dynamic strength of the cervix versus the structural length of the cervix. Understand what I am trying to say? As far as the cervical competency is concerned, it is the tussle between the dynamic strength of the cervix to hold the pregnancy versus the structural length of the cervix. And in clinical practice, you have seen a lady has got a long cervix, still she delivers preterm, and another lady has got a small cervix and she will go to term. So what is important? Is it the structural length important, or is it the dynamic strength important? And therefore, in one of our papers, this was done by my postgraduate student, Dr. Urvi, and here we studied 500 low-risk pregnancies with low-risk singleton women who underwent two-step cervical screening program, two-step cervical measurements, one at the time of anti-scan, another at the 18 to 20-week scan, transvaginal route. No intervention was done, and we studied what is the duration of pregnancy. And what we found out from this paper is that if the cervical length decreases to more than 6 millimeters between these two readings, that is the reading at first trimester and reading at second trimester, her chances of delivering early are extremely high. We sort of did an experiment, and another one of my other student, Dr. Anamika, she helped me, Anamika rather, her husband helped me in designing a tool, and we call this as a DCA tool, or a dynamic cervical assessment tool. And the time you need to feed the cervical length at the time of 11 to 12, at the time of 12-week scan, another cervical length at the time of 20-week scan, and the software or this algorithm will understand what is the difference between the two cervical lengths, and will try to give you into a mathematical number chances or probability of this woman delivering by 34 weeks of gestation. Of course, my intention is not to give you a binary number, because again, it is very easy to understand because we want simple answers. And if I give you a number like you should act after a number of 60, then all women will receive intervention. So this is just a way of understanding what is the chances of this patient. For example, here is a lady whose probability of delivery by 34 weeks is about 60%, because the decrease was almost, by 8 millimeters. And in another woman, if the decrease is again by 9 millimeters, you see the chances again go down. So we have a very simple tool in our hands to prevent a spontaneous preterm birth. Ultrasound. At the modest cost of doing ultrasounds, you look at what are the savings are. The savings are in the terms of baby. For the baby, the costs are very considerable. And these considerable costs are not only an ICU stage and the financial cost, but it is a cost because of the probability that this baby is likely to suffer from RDS, suffer from bronchopulmonary dysplasias, intraventricular hemorrhages, not only the early complications or the immediate complications, the late sequelae like cognitive disorders, social and behavioral developmental problems. So the cost of screening women for preterm birth is extremely less, and that is just a cost of doing your proper ultrasound. If we compare the logic or the counter argument that we always face is that this will increase the number of scans we need to do. Yes, the answer is yes. Yes, definitely that will lead to increase in it will lead to increase in number of scans that we are going to do. But understand first, if you look at the cervical cancer screening program, if we screen almost 1,000 women, then you are going to pick up one patient of invasive carcinoma. If you screen 10,000 women, you are going to prevent 25 preterm births with a universal cervical screening programs, universal cervical screening protocols. We need to shift our focus to preterm births less than 34 weeks and not 37 weeks, because though births before 34 weeks of gestation represent only 1 to 2% of all births, but they account for almost 60% of all neonatal mortality, and nearly 50% of all long-term neurological sequelae are these group of babies which deliver before 34 weeks of gestation. Well, intervention, what the intervention could be, and again, we are searching for solutions for these women, and one solution we know is using vaginal progesterone, and that is proved to be effective in reducing the chances of spontaneous preterm birth. So what my last practice recommendation is, we should screen all women for risk of spontaneous preterm birth at 12th week, repeat her transvaginal scan at 20 weeks, document if there is any regression in the cervical length. If the cervical length is less than 10 millimeters, we offer them encerclage. If the cervical length is more than 25 millimeters, we just observe them serially. If the cervical length is somewhere between 10 millimeters to 25 millimeters, these women should be offered vaginal progesterone. Our DCA tool, or the dynamic cervical assessment tool, will come into this green zone patients where you are going to do a serial observation. And if the tool identifies that risk of this lady delivering early is high, probably these women will go for increased surveillance or they may still go on vaginal progesteron. Remember, a woman at cervix of 3.5 centimeters is also at risk of developing a spontaneous preterm birth. It's not necessary that cervix has to be 2 centimeters only that she will develop or she will end up, spontaneous preterm birth. So I think I've come to the end. I'm just quoting Socrates here. Today, the time has come for individualized care. I think we should have predefined disease-specific objectives before we touch the patient, before we accept the patient into our screening programs. And these screening programs will be giving a reassurance to the low-risk women, but increase surveillance in our high-risk women. And this future research will invariably expand the number of conditions that we are able to pick up at first trimester scan. To quote Nicolaides again, it is likely that the new challenges for improvement of pregnancy outcome will meet by inverting the pyramid of prenatal care to be introduced on a large scale and a systematic fashion, a new model of prenatal care which will be based on what findings we see at first trimester scan. I think changes. It does not have to be a rocket science. A change that can improve patients' health are often difficult to get into practice even when backed up by good evidence. And at this juncture, I would like to quote our experience or the experience of using steroids for preterm birth. There was an evidence to tell you that the steroids are useful for lung maturity. It took almost 30 years for this research to come into our clinical practice. So these are very simple changes, the changes that can improve the patient's health. But they are very often difficult to get into clinical practice even when backed up by good evidence. What we understand, the change is inevitable, the growth is optional. Of course, the acceptance of FTs into our clinical practice will depend upon the three factors, that is the affordability, accessibility, and availability. It will also depend upon the educational level of the clients that we treat for and the educational level of the doctors. But the most important is we need to understand is our own resistance in accepting the new scientific advances that are happening around us and get those scientific advances into our practice. My last slide, really. Actually, I like Sherlock Holmes. I really don't know how many of you like Sherlock Holmes. But to quote Sherlock Holmes, you know a conjurer. Conjurer is magician. You know a conjurer gets no credit when once he has explained his tricks. And if I show you too much of my method of working, you will come to the conclusion that I am a very ordinary individual after all. And that's very true as far as the scientific advances are concerned. I think education never ends, Watson. It is a series of lessons with the greatest to be reserved as the last lesson. Thank you very much for your patience hearing. If you have any questions, feel free to ask them. Thank you. And thank you, Leipzig, for giving me this opportunity to interact with my colleagues, with my teachers, and most importantly, with my students on a Teacher's Day. I think this has been a very, what you can say, a precious gift that I have received from your company. Thank you so much.